I'm going to turn it over to Dr. Murali Doraiswamy, but first I just actually wanted to make sure that we all thank him. In my time here over the past 3 years, he's been a fantastic leader, helping us always have a terrific program for the Karen L. Wren Lectureship, which is a great support in this area of work of dementias and Alzheimer's, and Murali's just has worked tirelessly to make sure we have an excellent program. So I just wanted to make sure that we all express our gratitude to Murali doing this work for us, and really grateful for him sort of leading this very distinguished panel in this discussion today. Thank you, Murali.
Thank you so much. It's an absolute pleasure working for you in the department. A warm welcome to everyone. I'm Murali Doraiswamy. It's my great pleasure to welcome you to Duke Psychiatry Grand Rounds and the Karen L. Wren Lectureship. Before I begin, of course, we have a very good turnout. I want to wish everyone on the call good health during this very challenging time. A few housekeeping notes. To reduce background noise, I believe we will be muting all attendee lines. If you have any questions, please submit them via the chat function, and we will answer the questions at the end of the panel. I realize that some of you may have to leave at 1 p.m. Eastern time, but the speakers will stay on for an extra 15 minutes to answer any questions in case some of you do have the time to stay behind. The session is being recorded, and it will also be posted in addition to the departmental Grand Rounds site. It will also be posted on a special YouTube channel that has been created for the Karen L. Wren Lectureships. Today's lectureship is made possible by a gift from the Karen L. Wren Trust and the visionary support of Marjorie Thomas. Marjorie is a distinguished alumna of the Duke Women's College, and she is the CEO at Ivanhoe Broadcast News. She is on the call today, and on behalf of the department and Duke University, I would like to express my deepest thanks for her support of both this particular lectureship and Alzheimer's research at Duke. It is now my great pleasure to introduce our distinguished speakers from the Lancet Commission on Dementia, and our speakers have been at the forefront of efforts to accelerate preventive strategies for Alzheimer's disease. Dr. Lon Schneider will serve as the chair and the moderator for today's session. He is the Della Martin Professor of Psychiatry and Neuroscience and Professor of Psychiatry, Neurology, and Gerontology at the Keck School of Medicine at the University of Southern California. He directs the USC California Alzheimer's Center. He's a world-renowned clinical trials expert who has served as a principal investigator on numerous landmark trials, such as the KT Alzheimer's trial that looked at the effectiveness of antipsychotics. I actually don't know any psychiatrist or neurologist living today who has published more papers in JAMA, Lancet, and New England Journal than Lon. And one time I actually was picking up a copy of Lancet and JAMA, and the same week he had an editorial in both journals. It is now my pleasure also to introduce Professor Gil Livingston from London. Dr. Livingston leads the Lancet Standing Commission on Dementia Prevention and Care. She is a professor of psychiatry of old age. She is the director of research and deputy director of the Division of Psychiatry at the University College London, also called as UCL. She is a leading authority on life course analysis of dementia risk factors and trials, very pragmatic trials, in fact, to test scalable interventions to delay dementia and help caregivers. She has served as the principal investigator also on numerous landmark trials, including of agitation and a very recent interesting study on auditory rehabilitation in dementia. She is a fellow of the Royal College of Psychiatrists and has received numerous awards for her work. The last panelist is Dr. Nahid Muqaddam, who is both a physician and a PhD scientist. She's an MD PhD. She's a senior research fellow and consultant in psychiatry at UCL's Division of Psychiatry in London. Her PhD and her subsequent work focuses on the study of health inequities in dementia services, understanding ethnic differences in dementia risks, and in using inter-ethnic epidemiology to find new ways of preventing and treating dementia. It's an honor to have all of you here, and I'm turning over this to Lon. Over to you.
Okay, well, thank you, Murali. I'm delighted to be here. I realize I am faced with one main cognitive challenge. That if I can meet that, I can get the slides working. And so here it goes. So do I have the slides up? So
Not yet.
not yet.
Well, you have the opening slide, the title slide.
Excellent. Then that follows.
Okay, great.
So thank you for the introduction. Delighted to be here. I'm most delighted to be able to moderate what I hope will be a vigorous discussion on Zoom, if vigorous discussions are possible on Zoom, with Gil and Nahid, and on the prospects of preventing late life dementia. I just want to make a few comments, a few sundry introductory comments, and one is a kind of Coles to Newcastle recognition for this is especially directed towards the residents. If they don't know that in many ways Duke Psychiatry invented at least U.S. geriatric psychiatry, if not world psychiatry, and did that through the leaderships of Dr. Vibhor Base and Dr. Dan Blaser, amongst others, who came and worked with him. And as early as 1950s, Duke established the Duke Longitudinal Study in Aging, and followed it up with other studies and other longitudinal studies, both in psychiatry and neurology, probably too numerous to name at the moment. And what is arguably the first geriatric psychiatry textbook was led by Drs. Bossi and Blaser in the 1980s. So again, in many ways, this is carrying Coles to Newcastle. I want to make a couple of comments about life expectancy, and especially in relation to prevention. Over time, over the decades, human life expectancy has increased, and this is a graphic showing that constant and monotonic seeming increase in life expectancy decade by decade. But you'll notice, if you can get close enough to your iPads to see, that at certain times around World War I and the 1918 flu pandemic, and then around World War II, there were marked diminishments, decreases in life expectancy. And I wanted to show that. I don't know if I have a pointer that's visible to you, but I wanted to particularly point out the effect of World War I, and then followed by the flu pandemic in 1918 and 1920, and the marked effect it had on overall life and quality of life. And obviously you can make that connection to what we're living through right now. This only goes up to 2015. The other, so one point is, it takes so little or so much to affect world longevity. The other comment is the other illustration here, and may be difficult to see, is one of these gold lines is overall U.S. life expectancy, United States life expectancy over time. This red line is life expectancy amongst Blacks, African Americans in the United States, all the way from 1900, from the time of Jim Crow, through to at least 2010 data. This gap here is remarkable and can be prevented, can be improved, and maybe we are improving it. The last point here on the slide, linking this back to the COVID epidemic, is this was just from a couple of weeks ago. The Washington Post did an analysis comparing expected deaths related to Alzheimer's disease and the excess deaths of patients with Alzheimer's disease or dementia over the course of the last 4 or 5 months. You can make your own inferences on why there would be such an increase in expected deaths. Obviously, mine is COVID-19. Just to take this another from another point, before turning this over to Jill, is another way of showing the secular trend for the decreased incidence of dementia. That along with increased longevity, there is a decreased age-specific incidence of dementia that at least within several cohorts, and here the Einstein aging cohort, Einstein Medical in the Bronx, illustrates this secular decrease in incidence here on the y-axis. So you might see that incidence in the 80 to 84 age band has dropped from about 4% in 1910 down to well below a percentage incidence per year. And I thought I'd put Ruth Bader Ginsburg right here in 1933 when she was born, to indicate that really the incidence of dementia is now fairly low in 80-year-olds born recently. And as I think you all know, although she suffered from numerous illnesses, including cancer, she was not in the least cognitively impaired at the age of
Lon, could you speak up a little bit? I think I'm getting some comments saying people are not able to hear your voice as well, if you don't mind.
Oh no, okay.
But that's much better. Thank you.
There's one unexpected delay there. Let me just also see, okay, I will speak up. The other part of the Einstein aging study was, or another observation in the Einstein aging study was that that this was the study that was associated with what I believe many of you have heard about dancing and doing crossword puzzles as preventing dementia in late life, as being a risk for or a risk mitigator for late life dementia. There's some reasons for this, but I won't go into it in the introduction. And then the last comment I want to make is essentially the modifiable risk factors, as Jill and Nahid will describe have potentially a much greater effect on onset of dementia than, for instance, some genetic and well-described genetic risk factors and biological risk factors, such as carrying an ApoE4 allele or having an amyloidosis on PET scan. Certainly, being heterozygote for an ApoE4 allele, being a heterozygote carrier, increases risk over lifetime. But then so is the potential for modifiable risk factors in midlife and later life to influence that risk as well. And this is an illustration again from largely Duke researchers and clinicians who undertook the TOMORROW study that used a risk algorithm that involved age and ApoE genotype mainly to predict risk over time. And you see in the left survival curve that in fact age combined with ApoE4 and another gene allele overall is associated with perhaps a 2.5% difference in time to the onset of mild cognitive impairment. This is again rather small compared to the potential for modifying environmental and developmental risk factors. I hope you are. I hope I am being heard. So, but without further introduction, I'm really delighted to be able to turn this over to Dr. Jill Livingston and Dr. Naheed Mukherjee for their discussion. Thank you.
Thanks, Lon. Over to you, Gail.
Okay, I'm just going to try to share my screen and get the right one. That's it.
And your voice is perfectly audible, so that's great.
Good. I speak really loudly, so I'll just continue to do so. So I'm going to tell you a little bit about dementia prevention and intervention from the Lancet Commission. There's a lot more to say, which I won't have time to, and you can read it online if you wish, and that this is the reference. It's a commission which was the product of a lot of work from a lot of people. So today, Naheed, Lon and I are here as part of it, but I'd also like to say that people who did a substantial amount, John Huntley, Andrew Summerlad and Sergei Kostfrieda also did a substantial amount with the new meta-analysis and that we did. So I'll talk about these as we go. So what I'm going to talk about, and I'm going to use some of the illustrations that Lon did, is why we should consider dementia as preventable. I'm going to discuss some of the individual risk factors and talk a little bit about population attributable fraction and future actions. So this is our meta-analysis, which came out in 2017. And what it shows is the decrease age-specific incidence of dementia in several countries, in Rotterdam, Bordeaux, the UK, and in a couple of studies in America. And they're all showing a decrease over time in the number of people in any age group that get dementia. So while there is a welcome increase in the number of older people as people survive for longer, there is more dementia as more older people, and that's particularly in low and middle income countries, but the incidence in some high income countries have decreased, and that's by more than 20% in the past 20 years. And that indicates that dementia is potentially preventable, but it's not just a secular trend. It's stable or increased in some countries. For example, Japan, South Korea, Hong Kong, Taiwan, India, and Brazil. So some countries have higher numbers per 1,000 or per 100,000 of older people, and others have lower. And it's interesting to think why that might be, and to try and act on it. So I'm going to talk a little bit about cognitive reserve, which I hope lots of people will have heard. If you look at this slide, if you look at the graph on the bottom left-hand corner, it shows the amount of neuropathology lesions in the brain on average of a cohort of people who had postmortems. And as you would expect, there is more neuropathology in people on average with late dementia than there is in people with early dementia, and there's more neuropathology in people with early dementia than those with low cognitive performance, who have more neuropathology than those with high performance. However, if you look at the 4 graphs above, they show individual patients. And you can see that, for example, if you look at the one saying early dementia, some people have early dementia with really quite small amounts of neuropathology, and some people have early dementia with quite large quantities. And these quantities are, and if you compare that with people with high cognitive performance, many people with high cognitive performance have more neuropathology than those with early dementia. And you could go through all of these and find the same. So on average, people have more, but some people have neuropathology and don't develop dementia. And this has led to the idea of cognitive reserve. And a reserve is the ability for an individual to tolerate neuropathology without developing dementia. And Stern and his colleagues have divided this up into neurobiological reserve, hardware, brain maintenance, genetics or lifestyle, and the third thing is the adaptability, which enables preservation despite neuropathology. And these 3 things make up cognitive reserve. And the important thing to understand is cognitive reserve is therefore not static. In adult life, we obviously have a certain amount of space in our skull, and we can't just keep getting more neurons, but lifestyle can make a big difference, and genetics, not really yet. So in 2017, we published the first part of our considering a life course approach to prevention of dementia. And what was important about that is that in some parts of the life course, something may prevent dementia, but it may not make a difference later on. So while midlife hypertension, when treated, leads to a reduction in dementia, in late life, people who are developing dementia, often their blood pressure drops. So actually having a lower blood pressure is not necessarily a sign of being at risk, but more a sign of having dementia if you previously had a high one. We took 9 risk factors, and we decided a priori, because people have different ideas about what were risk factors, to use the one that were mentioned in the National Institute of Health and the National Institute of Clinical Excellence. And we discussed them and came out with a life course diagram which suggested that over 30% of dementia was potentially preventable. And we compared that to the ApoE4 gene, which Lon talked about, and using the same methods, the number that you would come out with is 7%. And it just shows really what a difference lifestyle can make. Then we met again, and we came out with 12 to discuss what further risk factors that we would add, and we added traumatic brain injury, excessive alcohol consumption, and air pollution. And that gave us 12 risk factors. And we put these all together and drew this picture of it showing population attributable fraction of 40%. I'm going to talk a bit more about them individually in a minute, but what I'd like you to notice is that hearing loss, which initially surprised us, but I've got used to it now, was the most at 8%, and then education at 7%, and and then smoking. And if you put them together, that makes 20%. So 3 of the population risks account for half of them, half of the total risk. So when we discussed adding, as I say, we decided on traumatic brain injury, pollution and alcohol. We did not add sleep. We talked about it, and we put together a lot of work which show meta-analysis and systematic reviews, all of which showed that increased amounts of sleep or decreased amounts of sleep made you prone to, and often suggested cause dementia. And when we discussed it as a group, and I think that Lon was very vocal about this, we decided that's not biologically plausible. If sleep caused dementia, it should be either increased or decreased. It shouldn't be both. And that suggested 2 things, that a lot of the studies were looking at people with early dementia whose sleep had become disturbed, and other studies were looking at people who had physical or mental health problems which were causing changes in their sleep patterns. And while we're not saying that sleep we're not suggesting that we know that sleep doesn't definitively have an effect on dementia, we also thought it did not at this stage. It was not at the stage we could say definitively it did. Similarly, we looked at diet. And if you consider lots and lots of studies of individual vitamins and elements of diet, they are all negative when randomized controlled trials are done. To the extent the World Health Organization has suggested that nobody takes vitamin supplements, nobody takes B12, nobody takes B6, nobody takes E to prevent dementia. If you look at overall diet patterns, the evidence is inconsistent for dementia specifically. And that is probably because diet is very complex, it changes throughout life, and it's very much linked to people's socioeconomic status, linked to what they can afford and their education. So again, it probably is very good for you to eat a Mediterranean diet, but we are not able to say that not eating it makes you more likely to have dementia. We didn't really consider physical health as one of the possible risk factors. Since that time, Wallace with Ken Rockwood in Canada has published a study which shows that people who are frail are more likely to develop dementia with less neuropathology. So really it's the opposite of cognitive reserve. This is people who have a lack of cognitive resilience and need very little neuropathology before they develop dementia. And it's quite worrying in this COVID-19 era that a lot of people, older people, are presenting with delirium and perhaps brain damage, and we don't really know what the effect that's going to have in future, and whether this is going to make more people prone to have dementia. They're also suggesting that increasing people's physical health or decreasing their frailty may be another way of considering reducing dementia. So going back to what we talked about, hearing had the highest population risk of dementia. So that means that people, if we look at the population attributable fraction, that is how much of it in the whole population looks like it's due to hearing loss and might theoretically be avoidable, then hearing has the highest population risk. And I think it might be the next slide. No, it's not. I'll go back. Okay, so we did a systematic review and meta-analysis for the 2017 commission, and we found that we were only interested in people who had measured hearing loss many years before the possible diagnosis of dementia, because otherwise we weren't sure whether people might actually be in the process of developing dementia. And we found that the hearing loss almost doubled the chance of getting dementia, and that's people who had normal cognition 10 to 15 years later had twice the chance of getting dementia than those people who did not have hearing loss. At that time, we didn't know anything about the treatment. It caused a lot of concern. A lot of people said, well, all you're doing is that people who develop, it's the same pathology, it's just that people lose their hearing and then they develop cognitive loss. But since then, several groups have looked and been able to tell us that using hearing aids seems to make a difference. So one large study of almost 4,000 people found that if you looked at the people who used hearing aids, they had no increased chance of developing dementia 25 years later. Another showed that if they followed up people with hearing loss from the age of 65, those who didn't use hearing aids had much more decrease in cognition than those who did. And a nationally representative sample of 2,000 people who were tested for 18 years found that using hearing aids was the biggest protection from cognitive decline. Now, none of these are randomized controlled trials, and it may be that people who use hearing aids are people who have lots of very good strategies. They exercise more, they look after their blood pressure, they try to do more. But it still indicates that hearing loss is not just early dementia, because the people who treat the hearing loss do much better than the people who don't. And the mechanism we're not sure about, but one of the things that you can see in imaging studies is that hearing loss is associated with increased temporal lobe volume loss and decrease in hippocampi, which we'd expect to affect the memory. Education wasn't something that surprised us. I think that people are aware that education is important. And in our analysis, we looked at people who were educated up to about age 12 or 13 compared to people who were educated more. And they were much more likely to develop dementia. And that's an important problem in the world, with about 40% of people having less amount of education than that, but not such an important problem in the United States, where it's pretty rare. Since then, there's been more work, and it suggests that lifelong higher educational attainment decreases dementia risk. And in particular, education till age 20 is additionally protective. Past age 20, it looks like it has less effect. The brain is probably less plastic, and also it becomes less clear, because people who have more education tend to both have a more healthy lifestyle and to do more cognitively stimulating things. However, if we look at people in cognitively demanding jobs, we show that they have in general decreased cognitive deterioration. And there's some evidence that retirement may increase deterioration, even if you allow and take away from the people with ill health. And if you look at individual countries, those that have a higher retirement age have less rates of dementia. So probably we should all continue working if we can. I don't think it was ever any news to anyone that drinking very heavily affects the brain, but it's I think that what we did in our systematic review and meta-analysis, which he led for the 2020 commission, was we considered where a cut point might be. And there's a non-linear effect, and lots of studies have shown this, but people who drink more than 21 units a week in British terms, which is 14 drinks in American terms, and I just found out today 17 units in New Zealand terms, are much more likely to develop dementia, or they've got 20% chance of developing dementia compared to people who drink but drink less than 14 units. So it looks like, which is I think about 10 drinks in America over a week. So what might be regarded as not that high a level is still a risk for dementia, which many people just call social drinking. And interestingly, in France, the commonest reason for developing young onset dementia, the commonest association, is alcohol. We also considered traumatic brain injury. Traumatic brain injury comes from road traffic incidents, from military incidents, from sports, firearms, and falls. And we looked at all-cause traumatic brain injury, all severities, all causes, and all-cause dementia. And again, we found that there was an increase, a 1.8 increase in the chance of developing, 1.8 in chance of developing dementia. As you would expect, if it's a proper risk, then the more people have, the more injuries people have, and the more severe their injuries, and the more likely they are to develop dementia. However, I think that we've always known that some people, unfortunately, with a traumatic brain injury are left with a cognitive impairment. But many people are more likely to develop cognitive impairment, particularly in the first 6 months to about 15 years, but even 30 years later, they have a higher chance of it. Air pollution, we tried to do a meta-analysis on that, but we're unable to. But we found 13 longitudinal studies with between 1 and 15 years follow-up of air pollution exposure and incident dementia. And we found that it didn't really matter what it was in the air, it all increased dementia risk. We found it was too heterogeneous for a meta-analysis. So to calculate, we used data from the only study of all-cause air pollution with the outcome of all-cause dementia, which was in over 2 million people in Canada. Canada is one of the least polluted countries in the world, and we probably therefore have a very conservative estimate. But we calculated that the relative risk of dementia for those in the top 75% of pollution compared to the fourth was 1.1. Move on to hypertension. We've known for some time that persistent midlife hypertension increases the risk of late life dementia with a hazard ratio of about 1.6, so really quite a high risk. And as I said before, falling blood pressure without intervention in later life may be caused by dementia development. I want to mention the Sprint Mind study from the States, which I'm sure you generally know about. So it aimed to decrease systolic blood pressure to 120 compared to the usual previous risk of 140. And the control group, they aimed to decrease it to 140. As generally happens with hypertension studies, it had to be discontinued because the control group did so much worse than the intervention group. The Sprint Mind followed up people 5 years later and found that they didn't remeasure their blood pressure. We don't know what it was, but 5 years later, there was a significantly decreased risk of mild cognitive impairment, decreased by 20%, and there was a similarly decreased risk of combined mild cognitive impairment or dementia by itself, down by about 10%, suggesting really this is the only drug trial which has actually caused a decrease in dementia. So it suggests that antihypertensives might be very helpful. So social contact was the second thing that really surprised people after hearing loss. So people had thought that what's good for your heart is good for your brain. People had thought that keeping your brain busy is useful, but people hadn't really thought that either hearing or social contact. Now, the population attributable fraction of social contact is similar to high blood pressure and to physical inactivity. And we looked at this further since then, as have other groups. And Andrew Summerlad led this research, and when we thought about it, we thought that probably the thing that would cause most social contact is living with somebody. And we looked at lifelong single people, and compared to married people, they had a relative risk of 1.4, and compared to widows, widows had a relative risk of 1.2. So it looked like that's quite a high increased risk. We also looked at a study, and again, Andrew led this, a 28-year follow-up of over 10,000 people in the United Kingdom, and found the increase of having more social contact at age 60 was associated with a decreased dementia risk, and that was also true at age 50 and 40. So it looked like social contact protected from dementia rather than it was that dementia changed social contact. Similarly, a Japanese study of 14,000 people found that social contact was linearly associated over 10 years with a reduced dementia risk. So I'm not going to talk about it because we haven't got very much time, but when we worked out the overall change in dementia, we considered the fact of communality. We considered that people are not like lab rats, that risks cluster among them, and that when you look at the overall risk, the simple risk for hypertension, which is what I showed before, it's likely that hypertensive people are more likely to be obese, more likely to have diabetes, and more likely to be physically inactive. And we looked at all of these things and clustered for it and reduced the risk for communality. We still came out with 40%. Over the last few years, there have been some trials of multi-component interventions in dementia, notably the finger trial, which has gone on to worldwide fingers. That ran for 2 years and showed a really quite small difference in cognition, and that's been rolled out and trying in other places, and other multi-component trials which have found decrease in, none of them have gone as far as dementia in just time, but have found decrease in cognitive fall in specific groups, either people with hypertension or people with less education and more risk. But so far, to date, these trials are short. They've got small numbers of the highly motivated people, so that probably the people in the control group do quite a lot of the intervention as well, and they've been quite disappointing. Results from cognitive reserve modification of the whole populations or high-risk populations are more hopeful. So I show you on this slide modification of risk factors in other illnesses, which have really made a difference without randomized controlled trials. So I'm going to just talk about one of them, which is a UK example of John Snow. So John Snow and the Broad Street Pump. In London, there was an outbreak of cholera. And John Snow decided that he would try and find out what was causing it. And nobody else had really thought of doing anything like this at the time by putting dots on the map. So you put dots on the map of everybody who had developed cholera or died from cholera, and they were all round Broad Street, apart from one family. He was a great interventionist, so he popped round and visited the other family and asked them about, did they have any connection with Broad Street? And they said, yes, they did. They used to live there, they moved over, but they still went to get their water at the pump because they thought it tasted better. So John Snow said, and nobody said there was stuff in the water that nobody could see that was causing the cholera, and other people did not agree with him. So he broke off the handle of the pump. And since then, there's never been an outbreak of cholera in Britain. It's a highly interventionist and successful intervention. So my message is, there's a lot of things we can do to possibly develop dementia. And Naheed's going to talk a little bit more about them and about equality and the importance things that risk clusters in people who are more deprived, who are from minority ethnic populations and from low and middle income countries, and more can be done with them. All of us can talk at great length and in much more detail about this. And as I say, it's in the Lancet Commission, but thank you for your attention. I'm going to let Naheed talk now. I'm going to stop sharing my screen.
Okay, thank you, Jill. So thank you, Jill. So Naheed, I believe, is now working to get her slides up to share her screen.
Yep, and I need to work out how to do that, so bear with me. Very excited to be here. Thank you for inviting me. I'm just getting my slideshow up, and hopefully I should be able to share my screen.
While you're doing that, I'm I'm cataloging questions in the chat room, and please feel free to engage on the chat with other questioners or commentators as well.
So while Naheed's doing that, shall I talk a little bit about air pollution, or have you done it, Naheed? No, not quite. We'll be there in a minute. So I think that air pollution is interesting. As somebody mentioned, the air pollution is of course very linked to socioeconomic deprivation, and that people don't choose to live in polluted areas. They live there because they have little choice. So I think there's two things that make me think that it's very likely that air pollution does cause dementia. First of all, if you use air pollution in laboratory animals who don't have all of these problems of having to live in different places, then they are more likely then they develop particularly tangles and tau, but they're more likely to develop dementia. And then the second thing is there's been in the States and about to come out from China studies where there's been naturalistic interventions where air pollution has been decreased and cognitive deterioration has also been decreased. So it looks as if that it really could make a big difference, and it's not just socioeconomic. I'll let you talk now if you've managed. If you can't manage, I've got your slide.
I think I am sharing my screen. Am I not? It says you are screen sharing.
I've got your slide.
Sorry?
Your screen is
sharing your screen, but you need to bring up but you're sharing a folder. You need to bring up your Ren lectureship. And,
oh, it is on my screen.
If it's on your screen,
not on ours.
Try exiting screen share and then going back into screen share to find your slide.
Yeah. You're now done it. You just need to make it into slide. Yeah, done it. Brilliant.
Yeah. Okay. Great. Fine. Yeah. So anyway, thank you for having me. So and for the introduction. So as Jill said, I'm going to be talking about dementia risk reduction. What is feasible and practical, and also a bit about how to make it more equitable. So this work was sort of aligned with the Lancet Commission, but not published in it, and it should be being published in Lancet Healthy Longevity on the 20th of October. So you'll be able to read the published paper then. But this will be a summary, and this work was carried out with people from the London School of Economics and Political Science. So these are our co-authors, and it was funded by the ESRC. So as we've just heard, there are many potentially modifiable risk factors, but how practical is it really to prevent dementia by targeting these risk factors? What would this cost, and would the costs outweigh the benefits, or the other way around? And that most of this research is really based on people of European origin in higher income countries. So how can we make it more generalizable to other countries, and also to minority ethnic groups within higher income countries? We've talked about population attributable fraction. So this is really a theoretical construct. So it says that, so each of these little bubbles, and the bubble at the end is, in theory, if these risk factors could be eliminated, by what percentage would dementia prevalence fall? But of course, for many of these, you might look at them and think, well, how do you actually eliminate this risk factor? It seems highly unlikely that nobody will ever have hearing loss, or you will be able to get rid of all traumatic brain injury. And even if you do treat them, not everyone will respond to treatment, and some of these are not treatable, but they might be potentially targets for policy-based interventions. So what we set out to do was to try and see how many of these risk factors were potentially either preventable or treatable to the level at which they would then have a knock-on effect on dementia. So the first aim was to find effective interventions to change 9 individual risk factors. We started this work really after the first Lancet Commission. So we haven't looked for interventions for air pollution, traumatic brain injury, or alcohol. But as you might imagine, those are likely to require policy level interventions, and certainly traumatic brain injury will have a huge number of potential causes. So I think that this, we're unlikely to find discrete interventions for those that we could have costed up. So I think this is likely to cover all of the 12, although we didn't explicitly search for them at the time. So we looked for interventions, searching sort of online databases to look for interventions that would target these risk factors and that were shown to be practical, so I'll go on to this sort of inclusion criteria, but we wanted to find these interventions, model the costs and benefits of implementing them, and then I'll sort of talk about all of that and how we costed them and what the cost and benefit ratio was. And then at the end, I will talk about comparisons with other countries and also minority ethnic groups. So first, in the systematic review looking for interventions, we searched the Web of Science and PubMed up until March 2020, and we were looking for feasible interventions. So these were interventions that you could roll out in the adult population or in all adults with the relevant risk factor. There needed to be robust evidence that the intervention improved the risk or the risk behavior, and that, as I said, we searched for all of the 9 risk factors that were in the Lancet Commission 2017. So in terms of the impact, what we modeled was a societal perspective. So we took into consideration health costs of people with and without dementia, social care costs, and also informal care costs. So this is cost of family looking after someone with dementia. We also modeled the cost of the intervention, and this was derived from either standard costs of healthcare professional time or medications, or in cases where it was a specific intervention we were looking at, we used the costings that were provided in the paper that we were looking at. And then using a Markov model, we looked at the annual incidence in people with the risk factor. So for example, comparing people with hypertension and without hypertension and how commonly they would each develop dementia. And then applied the intervention, for example, antihypertensives, to people who we assumed were not already being treated. And then compared the incidence in dementia amongst those who were treated compared to those who were not treated. And we assumed that the risk factor would be controlled to the level that it would have an effect on subsequent dementia incidence. And then in the cost considerations, we had to look at the impact of dementia per person. So in terms of all of the costs mentioned previously. So all of this was fed into a model looking at incidence of dementia and then also progression through mild, moderate, and severe stages of dementia and eventually death. And then we calculated the cost per quality adjusted life year. So looking at the cost of the intervention minus the savings that we'd assume would be the savings that would be made if someone was prevented from having dementia, divided by the increase in quality adjusted life years. So our search really, we came up with really 4 interventions that met our criteria. So as you can imagine, for something like education, particularly in England, because we were modeling this for England. So in England, education up until the age of 18 is already compulsory. So there wasn't really any intervention that we could envisage rolling out to increase education beyond that. For example, for obesity, we didn't find any interventions that could be applied to the whole obese population that would reduce BMI to below the obesity threshold. So these were some of the reasons for excluding the other risk factors. And the 4 effective and practical interventions that we came up with in order to cost were hearing aids, antihypertensives, smoking cessation, and diabetes prevention. I'll just go through these briefly. So hearing aids is relatively straightforward. We costed for providing a hearing aid. So this included an initial visit for a hearing test and for fitting the hearing aid, the cost of that, the cost of the hearing aid itself. We also assumed that people would need regular checks, that they might need replacements after a certain period of time. So those were the costs that were modeled. For antihypertensives, we costed for medications. So, and we were very sort of conservative in sort of overestimating our costs by assuming that someone may need up to 3 antihypertensives in order to control their blood pressure. And for smoking cessation, we used a Cochrane review of smoking cessation therapy and found nicotine replacement therapy was highly effective and very easy to roll out in the population. And we used the example of nicotine replacement chewing gum applied to an older population. For diabetes prevention, we found finished the diabetes prevention study, which took a population at high risk of developing diabetes, and their intervention was sort of lifestyle, sort of dietary advice, monitoring by healthcare professionals, and exercise. And we chose diabetes prevention rather than diabetes treatment because there was no evidence that we found that treated diabetes was any less of a risk for developing dementia than untreated diabetes. And also for diabetes, because the intervention itself was quite expensive, we also did a sensitivity analysis where we costed treating diabetes so using metformin rather than preventing it. And what we found was that in England, if these 3 of the interventions were cost effective, hearing aids and smoking cessation saved money, antihypertensives were cost effective, but diabetes prevention was not worth it. So it didn't meet the cost effectiveness thresholds that are commonly applied. But if hearing aids, antihypertensive, and smoking cessation were rolled out across the whole adult population that needs them, this would eventually lead to an 8.5% reduction in dementia prevalence and lead to a savings every year of $2.4 billion or 1.9 billion pounds. So quite significant impact. So I think that was a sort of hopeful message that dementia can not only be prevented, but that efforts to prevent it by targeting some of the modifiable risk factors that we've reviewed would save money in the long term and eventually lead to a reduction in dementia prevalence. Which, using England as the sort of illustrative case, I think that would probably be generalizable to some other higher income countries. I think, the United States or other places with similar healthcare systems. But would these effects be the same in lower and middle income countries? So as part of another paper that we published in Lancet Global Health, we looked at the population attributable fractions for the same risk factors as in the Lancet Commission 2017, but using the data on the prevalence of risk factors from different countries from the 1066 study. So we looked at China, India, and 6 countries in Latin America, and found that actually in these countries, the potentially modifiable dementia cases were higher, a higher percentage than in our worldwide estimates, primarily because of higher prevalences of lower education, hypertension, and smoking. So it really highlights the importance of dementia prevention efforts being carefully tailored to each country's context, in order to be targeting the risk factors that have the biggest population attributable fraction in that context, and the ones that are most amenable to changing. And finally, I wanted to highlight, as you said, Lon, in your introduction about the gap in life expectancy between, in the United States, between white and Black populations. And I think this really highlights the inequality that there exists in, not only in life expectancy, but in the research that we do, that it's, that so many of our studies that we have included in our meta-analyses have been primarily conducted in mainly in white participants in higher income countries. If people from minority ethnic groups are included, they might not be separated out as separate analyses. And I think this is important because, because the minority ethnic groups will have a very different, or can have a very different life experience compared to the majority population. And this is one thing that we're looking at the moment, looking at these risk factors and their impact in minority ethnic groups in the UK using UK Biobank data. And what I've found is that for each risk factor that we've considered, the impact, so the increase in dementia risk is much greater in the South Asian population and the Black British population compared to the white British population. So for example, hypertension in our group increases dementia risk by about 30% in the white British population, but it increases it by almost more than doubles dementia risk in the South Asian population, and increases the risk of dementia by 2.7 times in the Black population. So, and this is sort of correcting for age, sex, and socioeconomic status. And it may be that, although we correct for these things in the models, that certainly that socioeconomic deprivation may, or that there may be other unmeasured confounders. But I think this is an important factor to consider. It might mean that dementia prevention efforts might actually go have more of an impact in minority ethnic groups. So I think this is an important area to be focusing on. So there may be the potential for even more benefit and and even more cost savings as well. So I think that's all I had to say. Thank you for listening, and I'd be very happy to take questions. And I will now stop sharing, hopefully.
So thank you so much, Nahid. Here's the awkward part of a Zoom conference when you can't actually interact or applaud or respond. So thank you so much, Nahid and Jill. So I understand from Murali that we have about 15 minutes, 12 minutes for questions. As you can see, if in the chat room, there were numbers of questions and comments, but maybe I can ask Jill to comment on James Burke's comment, James from Neurology and the Alzheimer's Center, on relationships between increased socioeconomic status and absolute reduction in risk. And then related to that is, in the kind of work that was done, how do you distinguish overlapping risks?
Yeah, I think the answer is with difficulty. So this is what I was trying to talk a little bit about the communality when we consider you consider in a population who has particular risks and which ones overlap, and you correct for that. So that's what we did. In some ways, I think sometimes when we correct, we might overcorrect for everything. So if you say, for example, lack of physical activity we're going to correct for socioeconomic class and diabetes and hypertension and sex and age, maybe you begin to lose what's there because there's so many risk factors, and it becomes difficult. And but nonetheless, I think that the numbers that we are getting are as accurate as can be and give some idea of the relative importance of these different risk factors. And we know that over the last 10 years on the high income countries people have looked at, there's been a high income Western countries, there's been a decrease in about 12.5%, and the 10 years before that there's also been a decrease in about 12.5%. I think it begins to give us some idea of the importance of these risk factors and looking at them, and that's probably related to decrease of hypertension, cardiac risk factors, cigarette smoking, and an increase in education. But if we had medication which was reducing dementia by 12.5 or 25%, that would be a miracle drug. And these risk factors are probably the understanding of them and our ability to change some of them, I think, are really, really exciting and give us real hope for the future that there won't be as many people with dementia. There'll still be people with dementia, but that many more people won't have dementia or will develop it later, and that's what it's the most feared. It's the most feared illness for people. It affects their families and it affects the whole of society as other people have to help.
Thank you, Jill. So Nahid, one or actually a couple of the commentators asked about physical activity, education, and obesity, and you put up what turned out to be a rather sparse model in which of risk or risk reduction in England specifically, in which you had to pretty much remove education and remove obesity, and I believe physical activity was not included. And I wonder if you could comment on that, if education, early childhood education is a risk, but if in many countries it's mandatory to receive a high school education, how do you factor that in and also factor in physical activity and obesity? I know I gave you a complex question.
Yeah, sure. I mean, I agree that, I think that all of these risk factors are important, but I think when we were doing this modeling, we really needed to have a concrete example that we could model costs and benefits for. And so for something like education, I think, again, this comes back to, that it might not be practical in England to make people go to university. But although we know that higher education, has additional benefits over and above, completing high school, but that this may be of benefit in other countries. So so I think the social context is important. And yes, there were many risk factors that we didn't include because unfortunately the literature on actual interventions that we could cost was just not good enough. So physical activity, for example, we found. There were interventions that looked at increasing physical activity, but either they didn't manage to increase physical activity, or they didn't manage to prove that increasing physical activity then led to a reduction in dementia incidence. And with obesity, again, people may have lost weight on interventions, but it didn't drop their weight below obesity threshold. So again, they would still be considered obese and therefore would presumably still have the risk. Depression was another one that wasn't in there because, again, like diabetes, treated depression is often lumped together with depression in meta-analyses. And so it still seems to be a risk factor. So yeah, so there were many that we couldn't model because the data just wasn't there. I can't remember if there was a second bit of the question, but I'm sure you'll tell me.
Gee, I wish I could remember it as well. I think in the interest in the next 6 minutes of trying to cover a number of points, I just want to recognize that a couple of questions were asked specifically about specific risk. Anxiety associated with, in particular, vascular dementia, or coffee consumption specifically. I don't know if either of you want to tackle that briefly, or perhaps I could simply say that, that there are multiple univariate risks that come out in one or another study. And part of the challenge in the commission, Lancet Commission, was assessing whether there was enough evidence from enough studies. Earlier on, so Duke has a world expert at Duke, epidemiologist Brenda Plasman, I believe is in the audience, and one of she wrote a seminal risk factor report for a state-of-the-art, an NIH state-of-the-art conference amongst others, but she has remarked numerous times, translating individual risks into action is relatively or can be rather difficult. And Jill and Naeem, maybe you'd want to either of you expand on the modeling and the translation of risks into clinical care.
Can I say something about that to begin with? That Public Health England, and obviously we have very different health models in England and in the United States. But Public Health England have a middle-age check, and building a midlife check, and building on the Lancet Commission, they have begun for everybody to look at risk factors for dementia and give them a personalised profile of risk, and say, everybody knows that you should exercise more and be thin and do things, but for you personally, you have high blood pressure and you smoke, and this is likely to lead to a much higher risk of dementia, which you really don't want to have. So you could change that. They haven't done a full assessment on it, but preliminary, they think that giving people individual profiles really helps them change. I also think that a lot of what we need to do is consider policy. That smoking reduction, somebody said, James Burke said in the chat, has been a major public health success, which it has in some countries, and certainly in United States and United Kingdom. And public health can really make a difference. A lot of the way we live can be very obesogenic. Certainly in this during the epidemic, I moved from my bedroom to the living room and sat still for 10 hours. But if you have if you change the environment, if you make it not much cheaper to eat high calorie foods, if you make it that it's easier to walk and use public transport than it is to drive, it changes people's behavior. And a lot of it requires change in policy, not just change in individuals, to really make a difference. But certainly it's a difference that might be worth making.
Thank you, Naeem.
No, I mean, I agree with what Jill said, and I think the challenge with these things is to to make it part of regular health screening and regular health systems, so you're not sort of battling against systems that are already in place, and trying to make things as practical as possible and tailored to people's individual risk profiles.
Another question. Well, I think Dr. Doraiswamy will tell us when to stop. But another question raises the distinction between tobacco smoking, cigarette smoking as a risk factor and nicotine consumption. What is, do either of you want to take that on whether the evidence is for nicotine being a risk or smoking, or both?
I don't know about nicotine. I know about smoking. I don't know if you know, Lon, or if Naheed knows.
Likewise, I think I know the evidence for, I'm not aware of any studies that have looked at nicotine exposure specifically. And yeah, and then of course vaping is another sort of relatively new thing. I don't know if that has the same risk as smoking. I imagine that all the stuff in cigarette smoke is not good for your brain, but yeah, I'm not aware of evidence separating out the different factors.
Oh, there are three products at play here. One is nicotine itself. The other is tobacco leaves, the complex chemistry of tobacco leaves, and then the other is actually burning stuff and bringing it into your lungs. So, thought we could try to address that, and there's a certain uncertainty. You might think that nicotine might be and separate pharmacologic evidence might suggest that nicotine at the right dose and the right time could be somewhat and in particular cognitively enhancing, or at least attentionally enhancing and maybe neuroprotective, but there's really no evidence, no practical translatable evidence. Maybe the last set of questions that I see here, or that I've copied down, is that there were another number of comments and questions about hearing loss in midlife, about the nature of the loss that might be a risk, and then about specific associations of a hearing loss with changes in MRI volumes, or perhaps in functional in regional functional activity as well. Do either of you want to further expand on midlife hearing loss?
I mean, I saw the question about the MRI findings and what specifically, which volumes they relate to, and I'm afraid I don't have an answer about that. I think the evidence for hearing aids is very strong, which makes me think that you know, that losing your hearing is a risk factor and not just a part of a prodrome or you know, a general lead up to dementia. So I think there's strong evidence for that. There's also work by I think it's Ken Dawes looking at sort of the links between, you know, how the mechanism by which hearing loss might cause dementia, and there's sort of links with both depression, but also sort of lessening social contact, both of which are also related to increased dementia risk. So so I think it's fairly convincing as a risk factor. There was a recent paper that came out, the Brenowitz paper in neurology, looking at polygenic risk scores for, and they didn't find that the hearing polygenic risk score was associated with dementia as a clinical outcome, but that the dementia polygenic risk score was associated with hearing loss. And I'm not really sure what that means, and I don't think it really explains the effect of hearing aids in sort of reducing people's dementia risk. So yeah, I think it's fairly convincing, but to be explored, I think.
Well, I think also with Zoom conferences as well as live conferences, it's fairly important to end on time when possible. And so with that, let me personally thank Jill and Naheed for taking the long trip across the pond, and thank the audience for listening and turn this back to Dr. Doraiswamy for concluding remarks.
Thank you so much for all of the panelists. This was really terrific. You can see from the comments that people really enjoyed this opportunity to discuss modifiable risk factors and interact with the Lancet Commission. There are many people at Duke who work in this area, and so please, there's a possibility that you may receive queries from them, and we would welcome any collaborations between the Lancet Commission, of course, and Duke faculty members. So with that, I want to just thank everyone. I want to thank the Wren Trust for supporting this lecture and wish everyone a nice afternoon or evening or night, wherever you may be. Okay, well, cheers and
Thank you.
goodbye,
Bye.
everyone.
Thank you so much.
Thank
Bye.